Hello. We are here with another episode of Let's Talk Health. And what we're going to talk about is what are the evidence-based nutritional medicine strategies for managing the PCOS. Hello. My name is Qurat, and I'm a senior nutritionist and wellness consultant in Hong Kong, MBBS licensed in Pakistan. So let's talk about what is PCOS. It's basically a common hormonal disorder affecting women of reproductive age, often leading to irregular periods, excess androgens, and ovarian cysts. So it's if I cut it down into smaller words, it's actually a misnomer, meaning what does it say it doesn't mean, like polycystic, having so many cysts in the ovary, syndrome, leading a group of different diseases. Actually, what it says, sometimes it does mean that, but it doesn't mean that all of the women with PCOS have ovarian cysts. So let's talk about what is the prevalence of PCOS. It's basically it's a common endocrine disorder and affects up to 1 in 6 women of reproductive age. And it's pretty common, and different criteria of PCOS depends on the geographic and ethnic variability of the presenting symptoms. It also depends on the lack of specificity of the symptoms, timings, and presentation. So according to research and different published journals, its variability depends on these factors. Let's talk about what is menstruation cycle in PCOS. Does it really affect it? Yes, it does. Actually, in order to understand how it affects your menstruation, you need to understand what the menstrual cycle is. So, as according to this slide, you can see it here. It's basically a combination of 4 phases: the follicular phase, ovulation phase, luteal phase, and the menstrual phase. So it starts on the menstrual phase, but then it takes around 28 days to complete one cycle. So it's really important that your follicular phase and ovulation phase are accordance to the number of days, more or less, according to the natural cycle. So if your period is irregular, for example, it comes more frequently than 21 days, or it becomes more than 35 days, so the length of your cycle depends on the hormones that are regulating your menstrual cycle. So it's important to know that whether you're having amenorrhea or you're having oligomenorrhea. Amenorrhea meaning having absence of menstrual cycle, and oligomenorrhea means having infrequent periods. This is important to understand that these symptoms are part of your PCOS. So once this is clarified, let's move on to your ovaries in PCOS, how they are affected. So basically, the PCOS ovaries are the accumulation of cysts in your immature follicles. So in the normal ovary, there's a whole cycle of perimortal follicles, primary follicles, secondary follicles, and mature follicles. But that cycle is blocked due to some factors which we're going to discuss later. And once that is disrupted, your normal development of the ovary is basically stopped. So you start having multiple immature follicles, and those immature follicles are stuck inside the ovary, and they can't mature enough to release progesterone and other hormones which are regulated in your menstrual cycle. So let's talk about the hormones in PCOS. The menstrual cycle is regulated by FSH, follicular stimulating hormone, the estrogen, the luteinizing hormone, and your progesterone. So during your menstruation, your FSH value is a little low. And once it starts to ovulate, reaches the stage of ovulation, your estrogen and luteinizing hormone increases in concentration in your blood. Once your egg is released from the corpus luteum, that corpus luteum releases the progesterone, and that progesterone is so important in the regulation of your menses. Now, what imbalances do you encounter in PCOS? Your hypothalamus is basically the main signal releaser to promote the production of FSH and LH. Sends the signal to ovary, and then that ovary increases the cortisol and androgens, and those androgens are released from the adrenal glands, resulting in lots of testosterone and insulin resistance. So this mechanism is important to understand before we further move on to the symptoms, because this hormonal imbalance is the main core of the problem in the whole of this disease. What do you see as in your skin in PCOS? Does your skin get affected? Yes, it does. You see dark patches or skin tags on the skin, a lot of acne because of the oil production. So your whole skin is basically regulated by the menstrual cycle, and it affects your skin changes. For example, in your menstrual phase, the skin becomes dry and dehydrated. You're more prone to have atopic dermatitis and contact dermatitis, while in follicular and ovulation phase, skin is usually calm, plump, and radiant, becomes beautiful, smooth, and it's best around ovulation time. But in the luteal phase, 70% of the women experience mild acne, greasy hair, eczema flare-ups. Skin is more sensitive to irritants. So once you understand that how your skin changes are linked to the menstrual cycle, you will understand that your skin is basically controlled all by these hormones. So how do you diagnose PCOS? In medicine, there is a Rotterdam diagnostic criteria to diagnose the PCOS. So there has to be 2 out of 3 criteria. Number 1, either one should have clinical hyperandrogenism, or irregular menstruation, or polycystic ovaries on having an ultrasound checkup. So any 2 out of these 3 has to be positive in order to diagnose it as PCOS. So the question arises, how often is amenorrhea related to PCOS? Let me clarify, what is amenorrhea? Amenorrhea is lack of menstruation. And the other question arises, how frequently does PCOS occur in women of reproductive age? So polycystic ovarian syndrome causes 85% of oligomenorrhea, means infrequent menstruation, and 30 to 40% of amenorrhea. So these are the facts and figures you can see on the slide, that how much percentage it affects in the reproductive women age. So does it one size fits all? Well, no, that's not correct. PCOS criteria does not fit everyone in that. So there are different phenotypes A, B, C, or D. So according to the Rotterdam criteria, one has to have either of the two, as I explained before. Either they can have all three symptoms of hyperandrogenism, or oligomenorrhea or anovulation or polycystic ovaries, or they can have phenotype B, having only the oligomenorrhea or anovulation or hyperandrogenism. They can have phenotype C, which includes the polycystic ovaries, does not have any menstrual irregularities, but have higher levels of testosterone and androgens, or phenotype D, which includes the menstrual irregularities, polycystic ovaries on ultrasound, and no hormonal imbalance. So this is important to understand, that which criteria of phenotype that you exist in. So you can't just diagnose yourself on this basis. You need to go to your health provider and get yourself diagnosed properly. But this is just for your general information, that you